the presentation with thanking Association of Clinical Chemistry and Lab Medicine Practitioners for giving us this opportunity to present the PG seminar. I would like to extend my thanks to the Department of Biochemistry at AIIMS Patna for their guidance and support. Uh, Today's topic is on aneuploidy detection, and the points to be discussed will be as follows: introduction, significance.
Just 1 second, sorry, my mistake. Yeah.
Introduction, then we lead on to the significance of aneuploidy, the methods of detection of screening and diagnostic tests, and then timeline with limitations and risks. Yes, sir. Now let's move on to what is aneuploidy. Aneuploidy is any abnormal number of chromosomes, that is, absence of or presence of an extra copy of chromosomes. It arises due to errors in meiosis and can lead to chromosomal anomalies like trisomy 21, 18, 13, monosomy X, and Klinefelter syndrome. Yes, sir. Now, after understanding what is aneuploidy, let us begin with the clinical importance of aneuploidy. That is, why is it important to study about it? It actually accounts for 50% of cases of spontaneous abortion in the first trimester itself. And it is the root cause of perinatal mortality and handicap, for which the risk increases with advanced maternal age. Yes, sir. And now let us see the prevalence of aneuploidies. Here, we can see that with advanced maternal age, the incidence and prevalence increase. So for trisomy 21, at the age of 20 years, the risk in the fetus is 1 in 1250, while at the age of 40 years, it is 1 in 86. It is the most important and most prevalent trisomy, followed by trisomy 18, which, uh, which is about 1 in 333 at the age of 40 years. Then we have 6 chromosomal anomalies, of which the most common is Klinefelter syndrome. And the only viable monosomy is the monosomy X, that is Turner syndrome. Yes, sir. Here we can see that most common is trisomy 21. Now, let us see why we are reading about Down syndrome. Down syndrome is actually the most important trisomy since the survival rate of the fetus is very much, and the fetus born will be handicapped for life. So here we'll see the burden of Down syndrome in India. The prevalence of Down syndrome is around 0.81 to 1.5 per 1,000 live births in Indian population. Around every year, around 30,000 to 35,000 people are born with Down syndrome in India. So here's a need of early detection and effective management. Yes, sir. Here in this chart, we are showing trisomy 21. So now let's come to the screening and diagnostic methods. So what is prenatal screening? These are the tests conducted during pregnancy, and it assesses the risk that a fetus may have of certain genetic, chromosomal, or structural anomalies. These are actually non-invasive in nature, and they can just aim to identify pregnancies that have an increased risk of aneuploidy. Yes, sir. So now we come to the spectrum of prenatal screening. Prenatal testing, which comprises of screening and diagnostic methods. Screening associates only risk, and the risk is based on biochemical, radiological, and demographic profile, while diagnostic tests are based on genetic makeup. The screening tests are biochemical markers with and without radiological parameters and non-invasive prenatal testing, while diagnostic tests are chorionic villus sampling, amniocentesis, and chordosynthesis, which is followed by genetic analysis. Here are the various timelines for various diagnostic and screening tests. We have first trimester screening test, the dual marker, which is done at 11 weeks to 13 weeks plus 6 days. Then we have second trimester tests like triple marker and quadruple marker, which are done between 15 weeks to 21 weeks plus 6 days and 15 weeks to 22 weeks plus 6 days respectively. We also have another method which has 99% sensitivity, that is non-invasive prenatal testing, which is done anywhere after 10 weeks. And then we have tests for diagnosis like amniocentesis, chorionic villus sampling, and chordosynthesis. Amniocentesis is done after 11 weeks. And then chorionic villus after 15 weeks, chorionic villus sampling is done at 11 weeks, and this can be done after 18 weeks after the visualization of pod. Now we'll discuss the first screening method, that is dual marker test. A dual marker test is the ideal screening method as it has highest diagnostic value amongst all traditional first and second trimester screening methods, and it shows finest correlation with karyotyping results. It is done in the first trimester from 11 weeks to 13 weeks plus 6 days, and it can provide early detection and effective management. And for Down syndrome, it is 90%, while for other chromosomal anomalies like 13 and 18 trisomy, it is around 94%. Yes. Now, these are the tests that are included in dual marker plus radiology, that is combined first trimester screening. Uh, there are two biochemical markers and three radiological parameters. The two biochemical markers are free beta HCG and PAP-A, and the radiological parameters are crown rump length, nasal bone, and nuchal translucency. The, now I have depicted the values of free beta HCG and PAP-A for trisomy 21, 18, and 13. For trisomy 21, free beta HCG is elevated while PAP-A is decreased, and for trisomy 18 and 13, both are decreased. We have ground rump length, for which is the accurate which gives us accurate measurement of gestational age, and the normal value is 45 to 84 millimeters. Then we have nasal bone, which can be depicted as absent, present, or hypoplastic, which is an important marker of Down syndrome. Then we have nuchal translucency, which can be for which higher values can be associated with aneuploidies and structural defects. Yes, sir. Here is a report of dual marker test for which we have taken into account the clinical information of the patient, the ultrasound findings, and biochemical parameters. Here we can see that for clinical information, we have taken gestational age into account, that has been calculated using CRL. Then we have taken maternal history into account of insulin dependent diabetes mellitus, smoking history, then RH positivity or negativity, and certain drugs which are actually associated with aneuploidies. We have also taken into account the weight and gravity and parity of the patient. The weight is important as we have seen there have been number of particles that have suggested that increased weight has an increased chance of aneuploidy, while the maternal history is important because certain diseases like insulin dependent diabetes mellitus is uh, is required. The history is required to ascertain whether, because there's a change in biochemical parameters in insulin-dependent diabetes mellitus, that is decrease in PAPA. While while in patients having Rh negativity, there is increase in beta HCG, so this value is important. Now we have taken into account the ultrasound parameters of CRL, NT, and NB. And we have also taken into account the biochemical parameters of PAPA and beta HCG. And for this just particular gestational age, that is 12 weeks plus 6 days, we have adjusted it using the median values that has been given for 12 weeks plus 6 days, and it corrected it for this particular patient using the maternal history, and have calculated a MOM, that is multiples of medians. And then we have calculated the risk and plotted it in a chart. And the risk for Down syndrome is 1 in 250, while the risk of trisomy 13 and 18 is 1 in 100. And this patient, we can see, has been screened negative for this particular pregnancy. Yes, sir. Here we can see that how the screening methods have advanced from 1980s to 1990s. In the early 1980s, only maternal age was taken into account and the detection rate was around 30%, while after 1990s, we have taken into account maternal age with combined screening methods of radiological parameters with biochemical parameters, and we have come to 95% of detection rate. Yes, sir. But still, there are limitations for this test, such as there's a limited detection rate of 85 to 90% for Down syndrome. Then it is actually a screening test, so it can only calculate risk. And if it turns out to be high risk, then the patient has to go for diagnostic testing. It is dependent on skill, as we require accurate gestational age and nuclear translucency measurements. It is not effective after 13 weeks plus 6 days of gestation, and it has a high false positive rate. Yes, sir. Now we have another newer modality, that is the first trimester quadruple marker. It uses PAP-A, free beta HCG, AFP, and placental growth factor along with nuchal translucency. It screens for trisomy 21, 13, 18 along with neural tube defects, fetal growth restriction, and preeclampsia. And it has got a high sensitivity, that has sensitivity approaching to NIPT, that is 98%. Yes, sir. But still, there are limitations. Of course, it's a screening test, and and also it is actually not available or standardized in all the centers since it is a newer modality. It has got high false positive rates compared to NIPT. So uh, there may be cases where the fetus turns out to be negative while the report is positive. Then it cannot detect all the chromosomal anomalies, and it requires with invasive testing if results are high risk. Then we have another test, that is a second trimester test, triple marker. Triple marker is done at 15 weeks to 20 weeks of gestation, and it is now obsolete because of less sensitivity, and there are more affordable tests available, so it has become obsolete. Yes. Then another second trimester test is the quadruple marker, which measures alpha protein, free HCG, inhibin A, and estriol, unconjugated estriol. It is done between 15 weeks to 22 weeks plus 6 days of pregnancy, and it can detect trisomy 21, 18, and neurotube defect. Its sensitivity is around 80 to 85%, and it has a false positive rate of around 7%. Yes. Now, this is the second trimester screening and what it contains. It contains AFP, HCG, beta HCG, then estriol, unconjugated estriol, and inhibin A, and it can screen for trisomy 21, 18, and NTD. Then it also contains radiological parameters of femur length and biparietal diameter. Uh, for trisomy 21, there's an increased beta HCG and inhibin A, and the other two parameters are decreased. For NTD, we have only AFP measurement that has increased. And for trisomy 18, inhibin A is usually decreased or normal, and the other parameters are decreased. Then we have femur length, which is associated with uh, a shorter femur length is actually associated with Down syndrome. And it is actually a correct way accurate way for gestational age calculation. We have another parameter, biparietal diameter, that can be used to assess gestational age. Yes, sir. This is a report for quadruple marker. Here also we have taken into account clinical information, biochemistry, and we have interpreted it using MOM values, and the patient has screened negative for this pregnancy. Yes, sir. It has got lower sensitivity as compared to first trimester combined screening, and it also has a higher false positive rates. It is less effective in multiple pregnancies as it can assess the risk for that pregnancy, not that particular twin or fetus, and it cannot detect structural anomalies or non-chromosomal and non-trisomy genetic disorders. So here's the limitations. Yes, sir. Now we come to the last screening method, that is non-invasive prenatal testing. It actually uses cell-free fetal DNA that circulates in maternal blood, and this can assess the risk of certain fetal chromosomal anomalies like trisomy 21, trisomy 18, and 13. It can be done after 10 weeks of gestation. Yes, sir. Here is the method of doing NIPT. We have to take 10 ml of maternal plasma, then DNA is extracted using, then DNA is extracted by extraction kits, then sequencing is done. After that, after the sequences, analysis and reporting is done. Yes. Now we have two types of NIPT tests. There is a basic test and there is an extended test. Yes, these are the two reports. This is These are the two reports that show a basic test and advanced tests. The basic NIPT takes into account maternal history like maternal weight, gestational age, and then it has also taken into account fetal fraction for this particular pregnancy, and the fetal fraction here is 7.4%. And we can see that the result is validated because of proper fetal fraction available. We can see that it only screens for particular three anomalies and six chromosomal anomalies, trisomy 21, 18, and 13. This patient has been given low risk, so so this is a safe pregnancy to continue. Then we have advanced test, that is extended NIPT, along with the basic NIPT. It screens for all the chromosomes, and here we can see that all the chromosomes have been given low risk. As it calculates only risk, so it is given, NIPT results are usually given as low risk and high risk. Yes, sir. It's it's still a screening test, so the limitation is that we have to go for diagnostic tests if it has got any positive results. It may yield no results, that is, in case of low fetal fraction or maternal obesity, there may be no result. And there are, of course, high false positive rates in cases of maternal conditions of malignancy, mosaicism, etc. And it cannot detect structural anomalies. So we move on to the diagnostic tests now. Yes, sir. Now we come to the diagnostic tests. The first is chorionic villus sampling. So what is chorionic villus sampling? So chorionic villus sampling will of course be the biopsy taken from the chorionic villi. It is done transabdominally or transcervically, and here chorionic villi aspirated for chromosomal analysis. It can be done between 10 weeks to 14 weeks of gestation, and the results take time to appear. It can appear in 2 to 3 days. Yes, sir. Limitations and risks for chorionic villus sampling are that there is a risk of miscarriage, then false results can be obtained because of confined placental mosaicism. It is limited to early gestation of 10 weeks to 14 weeks. It cannot detect neural tube defects. Of course, there's a biopsy, so it cannot detect neural tube defects, and it can cause limb reduction defects. Yes, sir. Now we move on to another technique that uses blood sampling from the fetus, and that is cordosynthesis. Cordosynthesis will use blood sampling from maternal abdomen, and it can be done after 18 weeks of gestation after the cord has been visualized. And the results will take around 24 to 72 hours to come. Yes, sir. The limitations are that, of course, it is invasive procedure, so it carries a higher miscarriage risk. The risk is greater than amniocentesis or CVS because we are taking blood sample directly from the cord, and it can hamper blood supply of the fetus. It is done typically after 18 weeks of gestation. It requires expertise, and of course, there's a limited utility for structural chromosomal disorders, and it may lead inconclusive results in cases of mosaicism. Yes, sir. Then we move on to the third technique, that is amniocentesis. It is an invasive technique which can be performed from 15 weeks of gestation to delivery. It is used for therapeutic or diagnostic purposes. Yes. There are risk and limitations, of course, involved here also. It has got a small risk of pregnancy loss around 0.1 to 0.3%. Then we are taking amniotic fluid, so there can be amniotic fluid leakage also. The results will take time to come, around 10 to 14 days. And there's a window after which we can do it. That is after 15 weeks of gestation only we can do it. And as it is an invasive procedure, it usually causes anxiety in the patients. Yes. Now, now after discussing all the screening and diagnostic tests, we move on to the body that actually governs the quality assurance and is required for developing validated algorithms for prenatal testing and diagnosis. So here comes Fetal Medicine Foundation. Fetal Medicine Foundation is a registered charity that actually aims to improve the health of pregnant women and their babies through research and training in fetal medicine. They have introduced various educational programs for healthcare professionals and doctors, and FMF has also donated around 45 million euros for scholarships and research grants in last 25 years. Yes. Now these are some FMF certified machines and softwares. The softwares are Astria, Brahms, Prisca, and the machines are Auto Delphia, Roche, Alexis, and Siemens Emulite. Yes, sir. Now, to summarize the topic, let us see the whole picture in detail. Usually, screening tests, prenatal screening is advised routinely to all the pregnant females, but still there are few candidates that are actually ideal for the screening tests, and they are any patient having age of more than 35 years or having any child born with Down syndrome, then if they have a screened positive for first and second trimester results and ultrasound findings suggestive of aneuploidy. These patients are advised genetic counseling, and they can be advised as screening and diagnostic procedures. For screening, we can advise them traditional screening methods like first trimester screening method and second trimester screening method. If the patient if the patient wants screening by first and second trimester screening methods, it's okay. Then we can categorize this patient as positive or negative screened. If the patient has screened out to be negative, these are advised routine care, and only routine follow up of the patient is required. If this patient turns out to be negative, it is the patient is advised diagnostic tests like chorionic villus sampling, amniocentesis. If the patient declines these tests because it is, of course, invasive procedures, so she can be offered non-invasive prenatal testing, which can be done after 10 weeks of gestation. The patient who goes for uh, all the patients who actually go for diagnostic tests are actually advised based on either screen positive results, or either if they have first trimester USG report as abnormal, that is high nuclear translucency, or second trimester ultrasound report as any structural anomaly. These are advised diagnostic testing. The patient may actually decline all these testing methods, screening and diagnostic methods, and then they are advised routine care only. While if the patient goes for NIPT, and then, if the patient goes for NIPT, there can be three types of situations. First, the patient has screened out to be negative. If the patient screens out negative, she is advised routine care, while if the patient is high risk or unclassified NIPT, and then she is advised for diagnostic testing. If the patient screens out to be positive, then diagnostic testing is required. Yes, sir. Now, to conclude this topic, there are a few points that we need to remember as it is an important topic clinically and diagnostically. So, prenatal screening should be advised to all the pregnant females, regardless of maternal age or risk. If the screening is accepted, then the patient has to undergo one prenatal screening approach. In cases, uh, then the patient is actually advise ultrasound. The first trimester ultrasound and second trimester ultrasound is actually advised to all the pregnant females. In case of first trimester ultrasound being abnormal, as in enlarged nipple translucency, or an abnormal second trimester anomaly scan, then these are offered genetic counseling and an ultrasound evaluation. Afterwards, if the patient screens out negative, the patient is told about that the risk of aneuploidy has substantially decreased, but if the patient wants to be sure, she has to undergo invasive testing. If the patient screens out to be positive, then the patient is offered counseling, and ultrasound evaluation is done, and diagnostic testing needs to be offered to such a patient according to the gestational age in which she is present. Yes, sir. Thank you.
Dr. Kanu, first and foremost, I'm pretty impressed by your confidence with all this glitch and giving a presentation to somebody else to manage a presentation and you talk on it. You've done a very good job. So I really appreciate your confidence. That's number one. The presentation you've made, personally, I found it very slick, very neat, very clean. You've touched all the important points, and that was quite refreshing. The text and the what do you call the blend of pictures go very well into it. So I was really impressed with your presentation and your confidence. Now I invite the judges um, to ask the to ask the speaker some questions. Dr. Ritu, madam, could you start?
Yeah, uh, it was actually a very nice presentation, and she took it from the very beginning till the latest concepts that have been there. So it takes a lot of efforts, and we all could see it. Thoroughly
Just,
enjoyed your presentation. It was
just
very
one second,
informative.
Dr. Kanu, you are doing you're reporting these tests in your lab.
Yes, sir.
Yeah,
So we are.
the way you talked, I could see that flavor in it. So it was very good.
So I actually wanted to know in how many days do you report the test? For example, if it is NIPT, so how many days? What is the turnaround time for the test?
Sir, ma'am, actually, we do the screening tests in our laboratory for
Huh.
a dual marker and quadruple marker. And
Okay.
then we have an associate, like there are so many labs associated with NIPT and amniocentesis. They
Huh.
are usually the patients are sent for further analysis if they require it. Because
So
it requires
yeah.
expertise. So,
No, but the
Uh,
turnaround time,
yeah. So for
usually,
yes,
example,
ma'am.
so the NIPT test, are you outsourcing it on your own, or it is going like you tell the patient that you have to do it outside only?
Ma'am, we actually tell the patient that it's done outside, though we know of a few labs that do it. So, if a patient asks, then we can directly inform them that these are the places from where they can get it done.
Okay. So what is the turnaround time for the quadruple test?
Around 4 to 5 days.
Okay. And any false positives or false negatives that you find?
Ma'am,
Have you come across any case like that?
there are less false positives reported in dual and quadruple tests. I've seen in the last 2 years, I've seen less false positives. Usually it is screened out as negative, but still there are chances of false positivity.
So, what I mean to ask is, was there any interesting case like you followed up till the end, or like there you found some abnormality and then you went on and had a chance to go through the report of further confirmatory tests like
Mm,
CVS or photosynthesis? Any case like that that you had come across?
yes, ma'am, I've seen cases where the patient has taken NIPT and the other patient who has gone for amniocentesis also. I've seen cases where basic NIPT has been done and extended NIPT has been done, both.
no, madam, the question is starting with you did the test and you correlate a high risk, and then they went on for this advanced test. And how did your results correlate with the advanced test results or the confirmatory test
Yes.
results? You followed any such cases?
Yes,
Okay.
Uh, Actually, if we follow up the such cases, it would be very useful for us also to document, and it will help us more to understand and deal with and to have a better connection with the consultant or the clinician and bridge the gap between the lab and the doctor. Second, it I understand that it was on aneuploidy, but I just wanted out of curiosity to know that any by any chance any blood disorders like thalassemia or sickle cell anemia also has been reported through CVS or cordosynthesis, or maybe through CVS,
Ma'am,
or do you come across?
I haven't seen it in our lab, but it can be done, ma'am.
Yeah, it is. It is
I'll
definitely it
just
is.
give I'll just give a small thing over here that please check up. There's a PPT which I had shared in the association, and I will share it up tomorrow also. It's called ABCD of antenatal thalassemia detection, where I've covered up all this process of how thalassemia gets, how the normal PCR machine will be able to do quite a bit, at least at 90% confidence of detecting thalassemias antenatal. So I'll share it up in the group again. Have a look at that.
Okay. That's all from my side.
Dr. Gautam?
Yes, sir. Uh, Dr. Kanu, it is a really very nice presentation. You had taken it in a very smooth way, starting from the basics to the thing, as already everyone was telling. My question, I had a couple of questions to you. You were reporting the this one, right? The dual markers as well as quadruple markers.
Yes, sir.
Regarding that reporting, I just want to understand your idea. What exactly is this MOM, multiples of median, and how it is being interpreted?
So multiples of medians is actually we have taken into account a baseline population.
Hmm.
For India, we have taken into account the Asian population actually, and we have calculated. We know a median, and so for this particular patient, if we'll just see the PAP and beta HCG. For PAP, we'll divide the patient's PAP values to this value, that is median population value of PAP for that particular gestational age, and then we'll multiply it by a correction factor, which will take into account all the maternal histories, that is the unmodifiable characteristics, and then we'll get an MOM. So this MOM, the ideal value is actually 1. That means that the patient's PAPA values and the median population PAPA values for that particular gestation age coincides with each other. Any deviation will mean that there's a risk of aneuploidy, as in if MOM is less than 1, that means that PAPA for this patient is high, and that's why this MOM has turned as less than 1. If the PAPA is low, then the MOM will be more than 1. And we can correlate it with this will actually distinguish and in a uniform way all the biochemical parameters and radiological parameters. And we can find it out using the initial method where we discussed that PAP-A and beta HCG values, what will happen for a particular trisomy, we can correlate it with that.
Okay. So overall, in the screening process, you are like we'll be having the biochemical as well as that dual marker, triple marker, and quadruple marker, and also we are having the NIPT, right?
Yes,
So
sir.
when it takes to the NIPT, what is the false positive rate?
Mm. So false positive is around 2 to 3%, sir. Yes, sir.
Okay, so this is 2 to 3%.
Yes, sir.
Okay, so there was in the last chart you were while you're summarizing it, you are telling that there is one thing is positive and the second one is negative, and in between there is one thing is the sample mis
Failure. Yes,
yeah,
sir.
sample failure. What exactly is that mean sample failure in NIPD?
So sample failure can be due to low fetal fraction, sir, that we could not actually validate this report.
Okay,
And
so what
yes,
uh,
sir.
Normally, the NIPT, we will be doing it at the gestational age of 11 to 14 or 11 to 15 weeks, right?
Yes, sir. After 10 weeks, it is
After,
acceptable.
after 10 weeks, it is acceptable. But what is the minimum percentage of fetal fraction to be there in order to get the NIPT result positive? I mean,
So according to Fetal Medicine Foundation, fetal fraction should be at more than 4%.
okay. More than 4%. Okay. What will be the other causes, like the way there will be false negatives can be happen? I mean, now I spoke to the false positive rate, right? So the similar,
Yes.
uh, the one of the limitations, it can also go for a false negative because the fetal fraction, as it depends upon the fetal fraction. Other than the
Hmm.
fetal fraction, is there any maternal factor which can be responsible to have the false negativity?
False negative in which the
It's not about the
fetus
fetal
generates
fraction, but it is about the maternal factor.
maternal factor of false negativity. So false negative. Mm. So usually it can depend on diabetes mellitus and yes, diabetes mellitus.
Okay. But how?
So biochemical parameters actually change in diseases like in insulin dependent diabetes mellitus. So it can result in false negative.
So one thing is, if you see the biochemical mark, like whatever the markers which we are analyzing for the aneuploidy, it
Yes,
is
sir.
for AFP, it is almost like alpha fetoprotein. The source is the fetal liver. Unconjugated estriol, it is again the maternal source. And PAPPA, beta HCG, everything is linked to the placenta,
Yes,
right?
sir.
What
So
is
any placental function is also impaired in diabetes mellitus, sir.
right? So that is what, because in gestational diabetes or chronic diabetes mellitus, there is a alteration in the placental function that result into the different or aberrant excretion of these parameters, and that's the why reason we can consider even like PAPA and beta HCG can also be considered in preeclampsia, right, as a markers.
Yes,
So
yes,
any
sir.
associated maternal conditions like preeclampsia or hypertensive disorders or gestational diabetes mellitus will also have the effect in ultimately getting into the, like, by interpreting this. That's the why reason it is going for modified MOM
Yes,
considering
sir.
maternal factors. Okay.
Yes, sir.
So once again, I congratulate you. It's really a very good presentation. Thank you.
Thank you, sir.
Okay, Dr. Kanu, it was very educative, very informative, and for all the people who are still joining with us, who are still there with us, we had a coffee with clinicians session with the obstetricians, and there also we talked a lot about these antenatal screening tests, aneuploidy screening tests, the values, how the clinicians interpret the results, and how their management is there. So that's also there in our blog spot. I would recommend the youngsters to go and have a look at it. uh, NIPT is something which is, I personally feel that all we as biochemists should get trained into it. We're leaving it to the domain of molecular biologists to do it. Then you have the pathologists who have got into the next gen sequencing in for cancers, and they are also doing this NIPT as a byproduct. That is actually our domain, and we need to actually jump into it. I'm not saying that straight away go gang ho and say, I'm going to start this in our lab. It's not going to work. But from the association level, from the institutional level, we should encourage our youngsters to go to these places like MedGenome is one. Go to places where they're doing this antibody screening. Just go for a fellowship, observership, get some ideas, okay, and keep a vision that eventually this is something that, just like pathologists and next gen sequencing for cancers is kind of taken up with the pathologist. I think we should claim our stakes for next gen sequencing using NIPT. And if we don't show our enthusiasm right now, we are losing something which we can reinvent ourselves. So just think this in mind before we can go ahead. And thank you all for your presentation. Thank you all for your active participation. The judges, Dr. Gautam and Dr. Ritu. Dr. Ritu, a special thanks to you for the presentation on Six Sigma. It's opened up my eyesight, or my eyes and my vision. And I kind of, tomorrow, let's go to the lab. I have the EQA results. I have the IQC results. Let's apply the Sigma scores. I would encourage all of you also to try to do that. Thank you very much. Welcome. Good evening.
Thank you.
Thank you, sir.
Bye. Good evening.
Bye, sir.